Hello, it's great to see everybody here today. What a wonderful place to be in Jalisco. A beautiful city, so it's really nice to be with all of you today. What I thought I would do today is really give you an overview of this area that we call regenerative medicine. This is actually a painting that hangs at the Countway Library at Harvard Medical School, and it shows the very first time an organ was actually transplanted. In the back room, you see Harwell Harrison retrieving the organ. In the front, you see the other surgeon getting their patient ready for the implantation, Joe Murray. This happened back in 1954. Before this time, the only thing that a patient with this problem would do is just wait to die. That's it. That was the only solution. So this single event changed the field of medicine because it gave you a chance to live on. This major accomplishment saved so many lives, but we're now dealing with major challenges. In a 10-year period, the actual number of patients on the transplant wait list in the U.S. doubled. In the same time period, less than 1% increase in the actual number of transplants. Why is that? We're living longer, we're aging better, and as we age, more organs tend to fail. So wouldn't it be great if we could regenerate ourselves? Is that science fiction? Not really. Actually, there are many things in nature that regenerate themselves. This is a salamander limb, and you can see what happens after a 2-week period. It fully regenerates, totally on its own. And the fact is that we are constantly regenerating. We're regenerating our cells in the skin. Every 2 weeks, the cells in your skin turn over. We're regenerating our bones. Every 10 years, the cells in your bone turn over. In fact, your body is constantly regenerating. The challenge is that it will not regenerate if there is injury or disease. And that's when scar sets in. And so part of the goal of regenerative medicine is to really harness your very own potential to regenerate and to make it better. And we do that using various strategies. We can use cells alone, cells and scaffolds together, or this other area where we call enabling technologies, things such as printing or bioreactors. So we can use cells alone. How do we do that? Well, the way we do that is we can go to the patient, we can take a very small sample of tissue, less than half the size of a postage stamp, and we then expand those cells outside the body. And these are skeletal muscle cells that we can then inject back into the same patient with their same cells that are muscle cells that will help regenerate their own muscle tissue. And this is actually studies that have now been completed for various indications in the area of muscle regeneration. We can also use cells and scaffolds together. What does that mean? If you have a structural defect, then you need to place the cells on a scaffold. What is a scaffold? A scaffold is they're basically materials. And so the way that this works is that we take a piece of tissue from the patient, and we can then expand the cells outside the body. So this is a patient here that presented with an injury. You can clearly see the gap here. This is a bladder, and at the top you see the bladder, and the bottom you see this organ called the urethra, which connects the bladder to the outside of the body. And what you see here is this major gap that's not there. So now we're going to replace this structure with the cells and the scaffold, this material that we create. And these scaffolds are nothing more than materials that look like a piece of your shirt or your blouse, but they're actually designed to go away. They're made with the very same materials that we use for stitches in surgery, where they go away. So 6 months later, these materials are totally gone. But we're using the cells to place on these materials. So here's the patient. We're going to show you what we do. We start with a patient on the top left. We take a very small sample of tissue, less than half the size of a postage stamp. We then expand the cells outside the body. We then, a few weeks later, we have enough cells to create our construct. We then take that material, that scaffold, that piece of material that looks like a shirt or your blouse, and we tubularize it, and we then coat the outside with the muscle cells and the inside with these lining cells, two major cell types in this specific organ. And we then put it in this oven-like device, let it cook, if you will, and we then put it back into the patient. Very much, I like to say, like baking a layer cake. You're creating these one cell layer at a time. So here on the far left, you see the patient's x-ray. In the second panel, you see the tubularized scaffold, the material that's going to disintegrate. On the final panel, you see the cells on the material. So what happens once this is inside the body? Once we place it back into the body, what happens? Well, this material starts to go away. It starts to dissolve. And the cells that we put on the material they can sense that their bridge is going away. And you know what the cells do? They start to lay down their own bridge. So 6 months later, you're left with the patient's own cells and the patient's own bridge. And the material that we put in is totally gone at that point. And that's exactly what we did. This is a study that we did with Dr. Atala Rivera. And you can see here the patient on the left with the actual defect. On the second panel, you see the fully regenerated organ in this patient. And this was 6 years after implantation. And we published that in this journal called The Lancet back in 2011. And we are now proceeding with the next set of the patient experience with these patients. Here's another strategy, another tissue that we put together. These are blood vessels. And we're using these things called bioreactors. We started to build these bioreactors back in the 1990s so we could condition these structures as we build them. So same strategy here. We take cells, we expand them outside the body, we create this tubular structure, but now instead of using urethral cells, we're going to use blood vessel cells. We coat the outside with a muscle, we coat the inside with aligning blood vessel cells, put it in this bioreactor, and let it mature, and then we implant it back as you see here. And this was actually placed in the carotid artery. This is the artery that goes from the neck to the brain, and we published that work in Nature Medicine. Here's another structure. This is a heart valve. Now, we have not implanted these in patients yet, but this is to show you how we create these structures. Same strategy. We create the scaffold, we coat it with cells, and you can see here the heart valve leaflets opening and closing in these bioreactors so we can implant them into patients. We've gone through about 2 new generations of this technology, and we're getting ready to move forward with an engineered heart valve technology this year, this coming fiscal year. Now, so far I've talked to you about flat structures such as muscle. Flat structures are the least complex. They're all complex, but flat structures are the least complex. Tubular structures, like blood vessels, have a second degree of complexity because they're tubular, 2 major cell types, and it's more complex architecturally. Hollow, non-tubular organs have a higher level of complexity. They're the 3rd level of complexity, mainly because the structure is more complex, the cells are more complex, and there's more interaction with other organs. But same strategy here. This was, in fact, the first organ we implanted in a patient, but I'm showing you these in order of complexity. If we had known then what we know now, we would have never started with a level 3 organ, but by doing so, we were able to go back to level 1 and 2 organs and make them easier as we build those. But same strategy. We take a very small sample of tissue, less than half the size of a postage stamp. We expand the cells outside the body. Once we have enough cells, there are 2 major cell types. Once we have enough cell types that we've grown, we then create the construct in the shape of the organ. We coat the outside with the muscle cells, the inside with the lining cells, place it back in this oven-like device, this incubator, and we then put it right back into the patient. And we published that work early on in that journal, Nature Biotechnology, and we then ended up doing our clinical experience in patients who had end-stage bladder disease. And you can see here on the far left the actual organ that was implanted. And you can see we published that in this journal called The Lancet. When we published that work, we also had a 6-year follow-up. And we're now getting ready right now to move on to the next phase of the trials in North Carolina. By far, the most complex organs are the solid organs, like the heart, the liver, the lung, because there's so many more cells per centimeter. So this is a major challenge, because nutrition is a problem unless you can get the nutrition to the cells. So around 20 years ago, we started looking at strategies to recreate solid organs. And we came up with a strategy where you can take a solid organ and you can use very mild detergents to wash the cells away. So we're using discard organs. There are many patients who die without having the ability to donate their organ because the organ's not good enough to donate. But we can reuse that organ. We can actually recycle the organ by using very mild detergents. So here's a liver. We take a liver, we use very mild detergents. 2 weeks later, all the cells are gone, and we're left just with the skeleton of the liver. However, it looks like a liver, we can hold it like a liver, it feels like a liver, but it has no cells. But now we're able to reperfuse this organ with the patient's own cells. So all that was left behind is that glue that kept the cells together, that bridge that kept the cells together. And of course, they will not reject because it's just the bridge, not the cells. So you can see here on this video how when we inject contrast, you can see this whole vessel vascularity has been preserved, and we can now inject contrast showing you that it's intact, and we can then perfuse cells in this area to reseed the organ and to create these livers that can function metabolically. They can actually secrete the things that livers secrete. Now, we can only make these about the size of a large lemon. But what we really need is about the size of a football. So we're working on how to make these bigger before they can be placed into patients. The other area that we looked at was how can we scale up these technologies? Everything I've shown you thus far, we're basically creating these tissues and organs by hand. But how can we actually create these and scale it up so we can make many of these organs at the same time? So about 16 years ago, we started looking at printing. And we started using your typical desktop inkjet printer that you see here. This desktop inkjet printer, we modified it so that instead of using ink, we started to use cells. And instead of using just a paper, we started to modify the printer with a 3D elevator. So every time the printhead would go through, you would print two-dimensionally over and over again to create three-dimensional structures. So basically, this is a cartridge. We use cells instead of ink. We then place that cartridge back into this desktop inkjet printer that we did this 16 years ago. And we then start printing this over and over and over again. And then there's a 3D elevator that lowers itself, and we can print this two-chamber heart that you see here. And then a few hours later, the whole structure starts beating, as you see here. Now, the fact is that we could prove that we could print these structures, but they did not have the structural integrity needed to be implanted surgically. So for the following 12 years, we started to experiment and build and design our own printers specifically to create tissues and organs. How do these work? There are 5 features that make these printers work for human organs. Feature number 1 is we use very small nozzles. These nozzles go all the way down to 2 microns. That's 1/80th the diameter of one human hair. That's feature number 1. Feature number 2, we're able to precisely lay the cells where they're needed. Feature number 3 is we use these special inks that allow the cells to go through the nozzle as a liquid, but once it hits the platform, it retains its shape. So the cells are not splattered, but actually can create the structure that we're building. The 4th feature is that we create this scaffolding, if you will, a highway system in a way that brings nutrition to the central portion of the construct, thus allowing the vascularity-like structure to be fed so that human-scale constructs can be built. And by doing so, we have now been able to build various human-scale constructs, as you see here, including bone, cartilage, and muscle. And finally, the fifth feature is that we use currently available 3D imaging systems that are available in pretty much every major hospital, where you can take an X-ray, and then through that X-ray, you can define what the organs look like. And what we did is we then designed our own software program, so we can then download this digital data into our own software program, and we can then drive the print head to print the structure that will specifically fit that patient. And we published that work in Nature Biotechnology back in 2016, and we're moving forward with this technology as well for patient use. This is our newest printer. We bring the printer to the patient. So we actually bring the printer, we scan the patient, and we print right on the patient. So on the top left, you see that video cartoon. On the top right, you see the actual printer that we built. And again, the way this works is you scan the area. That area gets transferred digitally to the printer, and then the printer goes in and lays down the cells where they're needed. Another application of our technology is for what we call the body on a chip. And this is where we're creating miniature organs, miniature tissue equivalents, miniature hearts, lungs, blood vessels, and we place these all on microchips. So we're combining regenerative medicine with a microchip industry, with biosensing, to create miniature bodies that we can then test, human bodies on a chip. Why is this important? Well, we can test drugs in this manner. Here's an example. This is a drug that was on the market for 11 years, Hismanol. And this drug had been tested by the pharmaceutical industry in cells, and there was no toxicity noted. It was tested in animals like mice and rats. No toxicity was noted. It went to phase 1, 2, and 3 clinical trials. No toxicity noted. It then was on the market for 11 years before there were enough cases in humans where they could connect the dots and say, this drug is toxic to the heart. It can be toxic to the heart. So the drug was pulled from the market, no longer available. So we were able to access this drug, and we tested in our body-on-a-chip system, and within a week, we knew that this drug was toxic to the heart, because this was a very sensitive system using human tissues, not cells or animals. Here's another drug. This is a drug called Resolin. It was on the market for 3 years. It caused 63 deaths due to liver failure. Same. This drug had been tested extensively on cells, rats, mice, and even small clinical trials. No toxicity was noted. It was not until a drug was released that this was actually found to be toxic. So we took the drug, tested in our system, and again, within a week, we knew that this drug was toxic. Why is that? Again, we're using human cells, and it's the actual direct effect on miniature organs rather than cells or animals. And so this technology can be used not just to screen drugs before they're released to humans, but now we're using this technology for personalized medicine. So at our center, there are 2 investigators at our institute, Alex Cardol and Shai Salker, who are actually working with our oncology team so that when patients present with a tumor and the biopsy, the small piece of tissue is taken for diagnosis, we take a little piece of it, we create what's called a tumor on a chip, and now we can test all these agents on the chip before it gets tested on the patient. So instead of having a chemotherapy agent that gets tested for 6 months and you see there's no response and you start all over again with another agent, and now it's a year and the tumor's too far gone, you can bypass that and try to give the patient the best medicine possible from the start. So what other things are out there for regenerative medicine? Well, the number one organ for need right now in terms of the transplant list is the kidney. 80% of the patients on the transplant list are waiting for a kidney. So same strategy here. We're able to take cells, expand them outside the body, create the structure of the kidney, the actual structure, and we then place that right back in preclinical models, showing that in fact we could create these miniature kidney structures that would secrete things that the kidney secretes. And we then went on to do a clinical experience where that's currently active, where basically you can go to the patient, take a small piece of their kidney, very small, less than half the size of a postage stamp. We retrieve the normal cells, expand those outside the body, create the structure, and implant it back into the patient. And this is the preclinical model showing you the two functional units within the kidney and the area that's going to be implanted in the center, and you can see all these new kidney units that were formed, all these functional units. And this is now in phase 2 human clinical trials in the US. So the strategy here is you always go to the patient, you take the specific tissue cells. That is, if we're making a kidney, we take kidney cells. If we're making muscle, we take muscle cells. From the same patient, we expand the cells outside the body, and we put them right back into the patient. So those cells already know what to do, and they're not going to reject because of the patient's own cells. But what happens if you don't have that cell type? What do you do then? Well, that's where you can use stem cells. Let's say that the patient was born without that organ. Or let's say the patient had an accident, and when the patient had the accident, they lost their only organ. What do you do then? Well, that's when you can use stem cells. A stem cell is a cell that can turn into any tissue or organ. It's a very specific definition. So in reality, there are only two cell types that have the definition of a true stem cell. Those are human embryonic stem cells or induced pluripotent stem cells, the ones listed here on the top. And both of these cells are true stem cells because they can really turn into many other things. They can grow rapidly, and they can just keep going and going. But unfortunately, by definition, these cells can form tumors. It's part of their definition. These cells, they're so potent that they have the potential to also form tumors. So that's two cells that are used. On the bottom, you see the more adult cells that can also be used. Fetal cord, that comes from the cord blood. Bone marrow, and other types. And these cells, you can't really grow them very well. You can't really expand them very well. They can't turn into many other things, but they will not form the tumors, but they can control inflammation. So on the one hand, we have cells that can turn into anything, are very powerful and can grow rapidly, but they can form tumors. On the other hand, you have cells that will not form tumors. They won't reject, but you can't really turn them into much, and they won't grow a lot. So about 16 years ago, we started looking at an alternate source of stem cells. And we postulated that maybe, perhaps, there's a stem cell population present in the fluid that surrounds the developing baby in the womb, what's called the amniotic fluid, and also the placenta, which is the afterbirth. So what happens when a baby's born? First, the water breaks, that's the amniotic fluid. Then the baby comes out, and then comes the afterbirth, which is the placenta. So we postulated perhaps the cells in the fetus that are going through the fetus continuously can be captured in the fluid and the afterbirth. And sure enough, we were able to find a stem cell population in these two sources. And these cells, just like human embryonic stem cells, just like IP, induced pluripotent stem cells, they can grow rapidly. They can turn into different things, into different tissues, but with one exception, they will not form the tumors because they're more developed. They're not as primitive as human embryonic and induced pluripotent stem cells. So this specific cell type can be derived from the amniotic fluid or the placenta at the time of birth. You can either use it as a stem cell without the worries of them forming tumors. And like adult stem cells, you can expand them, and you can also turn them into many different things. And you can store them for self-use so that you can use them as a depository for patients in the future. And we published that work, and these cells are now, when we published that work, we now have over 600 publications that you can see all over the world by multiple hundreds and hundreds of investigators working with these cells that are now, these cells are now entering the clinical stage. Now, they're now starting to go into actual humans. So what I've tried to do for you today is really give you an overview of some of our strategies in regenerative medicine. We have been working on about over 30 different tissues and organs. We have about a third of these already in patients, and our goal is to keep expanding the list of tissues and organs that we can get to patients. We have just an absolutely terrific team of individuals at our institute, over 450 people, all working together to bring these technologies from the bench to the bedside. So let me just give you a summary then of what we've talked about today. We've talked about using cells alone, the patient's own tissue-specific cells. We've spoken about using cells and materials together, like to create these structures that we put into patients. We've talked about different strategies, like printing, or using discard organs that we can recycle. We also discussed the 4 levels of complexity, with flat structures such as skin being the least complex, tubular structures like blood vessels being the 2nd level of complexity, hollow non-tubular organs like the bladder being the 3rd level of complexity, and finally, the solid organs being the most complex. We have now been able to impact all 4 types of tissues and organs by bringing these to patients. And again, the goal is to keep expanding that inventory of therapies that we can provide to our patients. And now just to leave you with a very brief video clip of a patient who was treated with one of these technologies, and this is from an interview that he gave 10 years after receiving his engineered organ.
I was really sick. I could barely get out of bed. I was missing school. It was just pretty much miserable. I couldn't, go out and play, basketball at recess without feeling like I was going to pass out when I got back inside. I felt so sick. I was facing basically a lifetime of dialysis, and I don't even like to think about what my life would be like if I was on that. So after the surgery, life got a lot better for me. I was able to do more things. I was able to wrestle in high school. I became the captain of the team, and that was great. I was able to be, the normal kid with my friends, and because they use my own cells to, build this bladder, it's gonna be with me. I got it for life, so I'm all set.
So that's Lucas Masella. As I mentioned, he's now 10 years out from having received his engineered organ. The fact is, we still have many challenges ahead. We really do. First of all, the cost of the technologies, scaling up the technologies, the regulatory processes that we have to go through, and so many more technologies that we need to move forward. And also the fact that no cell is perfect. We have to pick and choose the cells that we use for the technologies that we pursue. But despite all the challenges, we know one thing, and that is that these technologies do have the potential to make patients' lives better. And for us, that's the promise of regenerative medicine, to make our patients better. Thank you for your attention today.